Good evening and welcome all to Protection Summit. This night we have two elegant speakers. Myself, I'm Magdi Sharkawi. I'm professor of nephrology at Shams University, Cairo, Egypt. And we have with us Professor Valeria Casu from Italy and Professor Mohammed Abdelaziz from Cairo University, Egypt. We'll start the first presentation by Professor Valeria Casu. She is a stroke neurologist at the University of Perugia, stroke unit in Perugia, Italy. She earned her PhD from University of Perugia in 2003. She is also about to present a multi-center European project on primary prevention. Professor Valeria was the past president of the European Stroke Organization. She has authored and co-authored more than 200 papers and book chapters. Her talk today is about what is the comprehensive definition of safety for patients with non-vascular.
Thank you very much for your kind introduction, and thank you for inviting me. So, I will talk about something that for me, it's important when we're talking about vascular health. So I will share with you what is my comprehensive definition of safety for patients with non-valvular atrial fibrillation. So these are my conflict of interest. So as you know, I'm personally talking about stroke, and for me it's very important to prevent stroke, because even now we treat our patient very well. We have thrombolysis, we have thrombectomy, but still a patient will always remind the day before and after stroke. So something dramatic will happen in the moment that the patient has a stroke. So just to give you an idea, so in the world, every 2 seconds someone has a stroke, and every 5 seconds someone dies from a stroke. And when you look at yourself around, I always try to remember that in a room with 24 person, 1 of 4 will have a stroke. And this could be a little bit depressive, what I'm saying, but 80% of all stroke can be avoided. And clearly, in patients who have atrial fibrillation, we know that they need to be anticoagulated. But can we do more? It's more important that we look at the global aspect of stroke prevention. And just to remind you, the 29th of October is the World Stroke Day. And there is this year, this motto is join the movement. And it's very important to be active. So, as I said from the beginning, when we talk about stroke, we know stroke is a preventable condition. And this means that we have to look at the risk factor, and clearly one of 5 patients with atrial fibrillation had a 5-fold risk of having a stroke. And clearly anticoagulation is one of the milestones of our treatment, but it's not enough. We need to control the hypertension. We have to educate our patient in smoking cessation, management of diabetes, cholesterol management, avoid alcohol consumption, which is something more for northern countries where we have a high consume of alcohol. But it's a large condition, so you have to share with your patient the idea that we are not here to prescribe you some drugs, but we are here together to work on your health. And clearly, when we're talking about, as I said, a patient with atrial fibrillation have a 5-fold risk of having a stroke. And it's important, and something that we cannot ignore, that inside us there is an unconscious bias that we are afraid that giving a drug we can lead to bleeding. But this is this is a small aspect. This is an aspect that unfortunately can happen, but is the exception. And we can prevent this because we are giving health. We are preventing the most dramatic and serious evidence situation, which is an ischemic stroke. And we have to work on safety. So we have to understand the bleeding risk, which could be underlying. We have to help our patient to stick to the treatment, which is very important, because especially under anticoagulation, we cannot say, take the drug and that's it, bye-bye. We have to, in a way, make them understand it's important to stick to the treatment. It's very important to say we are protecting you to keep you safe from stroke. We are here to prevent the ischemic stroke. And what is also, because vascular, and then my colleagues after me will also remind this condition, it's important that when we are talking about vessel, it's for me clearly as a neurologist, the brain is the most important organ, but we cannot forget kidneys, we cannot forget the heart. So it's something that we globally need to protect. So when we talk about the typical case, we have Magda. She is an elderly lady. She has a non-valvular atrial fibrillation. She has what we expected, what she has. She's lucky because she reached the age of 82. But she has hypertension, diabetes. She had some what we call forgetfulness. She tends to forget things. She tends, like every elderly ladies, especially mothers, that tend to repeat everything every time, the same stories. Sometimes she's not sure about taking the drugs, and so on. And her renal function is going down. Her GFR is 55 millimeters per minute. So it's a typical situation. This patient is already treated with rivaroxaban once daily. So it's a situation that the relative, the son, will come to you to say, okay, I heard somewhere that there are lower doses. Should I reduce the dose? And you see this data from the Santux studies that the reduction of stroke over time in patients who newly started rivaroxaban was really important. So these are data from a registry, so real world data. So it's very important to see how these evidence are created. And again, when we consider the treatment of our patient, we clearly evaluate the whole of our patient. In the case of Magda, her age, her renal impairment, her polypharmacy, because she has more than one disease, her comorbidities. So it's important that we consider all the correct dosing and so on. We know that with the development of the NOACs, the reduction of stroke was in favor for NOACs, and what it's most important, we have a reduction of bleedings. So the safety, the global safety profile, the global benefit, clinical benefit, is due to the fact that we have less bleedings. And this is something that you see clearly is maintained also in the elderly patient group. And the point is that when you look at the randomized study, what we always say, you have wonderful patients because they're highly selected, they are too young, and they tend to have less risk factors. And as you see, in the Rocket AF study, the mean age of the patient was higher compared to the others. And they had an overall higher CHA2DS2-VASc score compared to the other studies, which means that they treated in this trial patients which are nearer to the real life. So what we really see in our clinical practice. And you see also the distribution of prior stroke, which is very important for me, the distribution of more diabetes and hypertension. So a globally important risk factor distribution. So we have randomized data from Rocket RF for the patient profile of our patients. So we have good data in an elderly patient about 75. And you can see that the odds ratio of having a stroke and of having an intracranial hemorrhage in patient is fully over. There is no interaction effect for age in patient treated over 75 years. This means a safety and efficacy profile. And you see also that there is from the real life, not only from the patients in randomized trials, a clear favor of patient treated by rivaroxaban in patient older than 75. Same, it's for the bleeding risk. There's a clear favor of reduction of bleeding. So what we really want from our patient is to prescribe a safe, efficacious drug, but at the same time have the evidence that we have at lowest possible the risk of bleeding. Because you cannot, when you confront yourself with the patient, you will say, I'm offering you the treatment of reduction of stroke, and the likelihood that you have an ischemic stroke is much higher than the small risk which you have to share. But you say, I'm saving your brain, I'm saving your cognition from embolic lesion. So I'm talking about a drug which showed me a safety profile, not only in the randomized trials, but also outside the randomized trials. Clearly, it's important, as I said from the beginning, it's important that you give advices. Because if you don't treat the hypertension, you will have a higher risk of bleeding. If you don't advise your patient to not to use antiplatelets, then you will have an increased bleeding risk. And you see, this is clearly shown by the Real World Prospective Registry, Xanthus, that patients who are treated for the modifiable risk factors have a lower risk of bleeding, and patients who are untreated have a twofold risk of major bleeding. What is about the kidney disease? It's clear that patients with non-valvular atrial fibrillation have a higher adrenal impairment, have a higher risk of bleeding and stroke. For me as a neurologist, it was clear that when I saw this data and I start to work more and more on primary prevention, I realized more and more that I have to, as you said, as I said from the beginning, evaluate the patient as a whole, as a whole vascular disease. So I have to look at the kidney function, because kidney function will tell me about the global risk. So I need to know how is the renal function, also as a marker of vascular disease. And you see, it's for me very important also to know about pharmacokinetic. And you see that the half-life is 7 to 8 hours for rivaroxaban, and the half-life in clearance below 30 is about 10 hours. So something that you have clearly an idea how the drug that you are prescribing is acting in your patient. what we know is that NOACs, at the beginning we learned, and when I started to prescribe NOACs, they told me, you see, when you have inpatient with renal disease, you should still use warfarin because they tend to have a better safety profile. But if you look at the data for creatine clearance, if less than 50, and you see that there's a clear benefit in stroke prevention and reduction of major bleeding in patients who are treated with NOAC compared to those who are treated with warfarin. And again, we have patients in the ROCKET trial which have a higher number of those who had impaired renal function, renal impairment. So again, we have real-world patients who were treated in the ROCKET trial. And as well, when you look at the distribution, and this is something that, again, it's this unconscious bias that unfortunately also we as physicians have, that this perception of the 2.5 twice daily is perceived extremely as safe. But look at the numbers. You are scientists, you are doctors, you have to read the clinical trials. And the reduced dose was studied in more patients with in reduced with 50 milligram of rivaroxaban compared to those who were studied in the Aristoteles trial. And you see that the use of NOACs is also associated with a reduced risk of decline of the renal function. And again, this was something at the beginning really not clear, that there is a clear protection of the renal function also due to the NOACs. And clearly, a reduction of the doubling of creatinine, acute kidney injury, and kidney failure. This is also from the Reloaded a clear reduction of risk of having dialysis for patients treated with rivaroxaban. How does it work? It seems that I will not enter too much in this because I'm not a specialist in nephrology, but clearly there is a reduction of calcification, and but this is a little bit too specific. I think my colleague will then speak more in details about this. Again, as I said before, there is a reduction of calcification in patients treated by NOACs. So the recent guidelines recommend to use NOACs in patients with AF and reduce the risk of renal outcome. And over the time, NOACs, particularly rivaroxaban and dabigatran, may be associated with lower risk of adverse renal outcome than warfarin in patients with AF. So again, what I said from the beginning is something that you will hear often repeated for me, that we need to globally protect our patient. So clearly there is less risk of bleeding in patients with ES-SARADA, with end renal stage patient. So this is clearly, there is a recommendation to use Xarelto once daily only. So just for the sake of time, I will focus Also on the diabetes, clearly that diabetes, 40% of our patients have diabetes, and diabetes is an independent risk factor also to decrease renal function. But again, we know that patients who were included in the ROCKET trial, again, we had 40% of patients who had diabetes. So again, we had a more studied population from the ROCKET AF arm. So again, we have evidence about the better tolerability, safety, and efficacy of a patient with diabetes and treated by rivaroxaban. So we need to using rivaroxaban, we tend also to reduce the risk of stroke, but also the risk of vascular death. So we have a reduction again in favor of rivaroxaban in patients with AF and diabetes. This is not consistent with the data with apixaban. So clearly data from the US database analysis showed that rivaroxaban reduced, as I said, all the vascular events in male in patients with AF and diabetes. And Caliber reminds us that rivaroxaban reduced the risk of worsening renal function versus warfarin in patients with AF and stage 3-4 chronic kidney disease. So unfortunately, what happens that in the real world, despite the fact, as I showed you before, there's a very small indication and small group of patients who were treated in the randomized trials with low dose. Unfortunately, in the real world, we see an excess of treating patients with low dose. And this is something that this is influencing the efficacy and the safety, because safety is not bleeding only. Safety is also protecting from ischemic strokes. And the difference to the other studies is that rivaroxaban is selected and in a consistent way from phase 3 studies, while, as I said in the beginning, the apixaban is overused, the low doses is overused in the real world. And clearly the reduction of the doses, when not justified, leads to an increased risk of stroke. And an increased risk of strokes means no safety, because you will have more ischemic stroke. So as I said, the underdosing is associated with higher risk of a patient treated with apixaban. And how many times you see this in the real world, that you find a patient with 2.5 milligrams twice daily instead of having the full doses. This is something that I just want to show you some data from our university. We wanted to understand why patients who were on NOACs developed or had a stroke. And you clearly see here that when you choose a non-label low dose, then you have a higher risk of having an ischemic event. So again, it's so important to treat the right patient with the right dose. And this is also another, let's say, data from our group, how you clearly reduce the risk of bleeding when you use the low dose, also the non-labeled low dose. But what you have here is even worse, because 80%, as I said from the beginning, 80% of all our stroke are ischemic stroke. So you have an unproportional high risk of having an ischemic stroke. And clearly, when you have twice daily to take a drug, especially in patients who have polypharmacy, you have a higher possibility that a patient tend to withhold the treatment, to interrupt the treatment, and because you have to remind twice daily compared to once daily. Again, what I said before, more important that suboptimal. When you have a suboptimal adherence, you have a risk of ischemic stroke. And this is how many times, and I see this unfortunately in my clinic, that patients who come to me with a stroke had a stroke due to a single dose when it was prescribed twice daily. So just to conclude, what we need, we need to remember that we need to prevent a stroke. That for me is number one, but clearly I'm as a neurologist, I'm working on this. We need to preserve renal function. We need to mitigate the bleeding risk. We need to prevent the cardiovascular death. We need to protect following stent replacement. We need to optimize the dose, and we need to support adherence. I think these are the pillars on which we work when we are talking about patients with anticoagulation. And this will reduce the risk of stroke. Just 2 words, because I think that is something that I learned in many of my travels, that unfortunately, in order to save cost, there are some bioequivalent used instead of the original drug. But bioequivalent are not the same drug, because you know how much it takes to get a drug approved, and it meets a phase 1, a phase 2, a phase 3 study, and then you have the data from the real world. So to say that a drug is equivalent is something that you need years of study in order to say we have the same effect as the original drug. And it's so important, especially when we are talking about anticoagulation, because you need to have the right effect in the right dose in your patient. So back to our friend Magda, please do not withhold treatment or do not reduce the dose because she is older than 80. It's important even more, the higher the risk is, the higher the vascular profile is of a patient, the more the patient need to be treated and need to be treated well. And nobody of us is free of this, because as doctor, we have unconscious bias. Sometimes we see this frail patient and we are afraid, but not treating is worse than treating her with the right dose. And so she was already on rivaroxaban 20 milligram. Leave her on rivaroxaban 20 milligrams. Thank you very much for your attention.
Thank you very much, Professor Valeria. This is a very comprehensive presentation. And I as I will postpone discussion till I am now honored to present Professor Mohammed Abdelghani. Professor Mohammed is the head of the cardiology department at Cairo University. Professor Mohammed was trained in Cleveland Clinic in Cleveland, Ohio in 1993, and then he took the fellowship of interventional cardiology, University of Pittsburgh Medical Center in Pennsylvania, 1998, and also trained in National Cardiology Institute in Osaka, Japan in year 2000. Professor Mohammed's presentation is about detecting non-valvular AF patient with diabetes and CKD. Professor Mohammed.
Thank you, Professor Magdi, for the nice introduction. Thank you, Professor Valeria. I enjoyed your talk. Actually, here we are a group of doctors from different states in the world, from Cairo, from Alexandria, and from Italy, and also different specialities, being a cardiologist with the neurologist and endocrinologist, always giving me the sensation of safety and friendly. Dear colleagues everywhere, I'm going to talk about a combination of atrial fibrillation, diabetes, and chronic kidney disease. But first, I'm going to share with you a picture from the Cairo University, and this is the famous dome of Cairo University in Cairo in Egypt. And this is the view from my hospital. This is the great River Nile, and this is the Ministry of External Affairs in Cairo, and this is Cairo by night. I invite you all to visit Cairo once we out of the COVID era. This is a celebration in my hospital of 183 years of medical education. Actually, Cairo University, one of the oldest in the Middle East. I believe this is a sort of clinical round when a teacher and the student share discussion and the patient is watching. Okay, now, dear colleagues, I have a patient. He is 76-year-old. He had non-valvular atrial fibrillation, diabetes, and moderate renal impairment. And he is worried. He came to me saying, "Doctor, I am afraid from the stroke. I had a friend with a stroke and this is awful. And I never want to go into dialysis. I don't want to live such a bad experience with dialysis." Actually, once I saw my patient is anxious, I immediately tried to calm him and try to put him at ease. But actually, my patient has a point of view. After he left, I sat down with myself. He has diabetes, non-valvular atrial fibrillation, and moderate renal impairment. Are these a common combination? Yes, it's common. Kidney disease occurs in around 1 in 3 patients with type 2 diabetes. Diabetes is a major cause of kidney failure requiring dialysis. Is right. And the combination of chronic kidney disease and diabetes are more likely to cause cardiovascular mortality. And even atrial fibrillation can cause a stroke more and more with age. My patient definitely has a point of view. And my rule, ladies and gentlemen, through the next few minutes, that, let us think together how we can offer the best strategy to protect my patient this evening. First, let us discuss the Shatz-Vasc score of my patient. It's 2 for age, 1 for diabetes, it's 3. 3 in the Shatz-Vasc score means annual mortality almost 6%. What about the Hess blood risk score, score of bleeding? By guidelines, I have to go for the Shatz-Vasc score and the Hess blood score. I have to evaluate my patient through these 2 risk score by law. So the Hess blood score of my patient is 2. He has 1 for the abnormal renal function and 1 for the age. And yes, he is right. Diabetes is associated with a 2-fold increase in the risk of stroke. Atrial fibrillation, as Professor Valeria clarified, may have a 5-fold increase in the risk of stroke in some series. And again, chronic kidney disease alone has 30 to 60% increase in the risk of ischemic stroke. My patient is right. And the combination of diabetes and kidney disease does not mean only increase in cardiovascular mortality, as we can see to the right in the light blue bar, but also increase in the total mortality. It's an awful combination. Diabetes and the kidney disease, more cardiovascular mortality and more total mortality. Compare this with kidney disease alone or with diabetes alone. Yes, combination is bad. My patient has a point. Okay, after good controlling of my patient, which strategy I'm going to adopt? Aspirin only, warfarin only, NOAC, or combination of aspirin and NOAC? To answer this, let us go to the guidelines. No, sorry, doctor, you are wrong. You cannot give your patient with non-valvular atrial fibrillation antiplatelet alone. It's 3 class of recommendation A. And again, sorry, doctor, combination of oral anticoagulant and the platelet inhibitors in such patient without a real indication for platelet inhibition, again, it's a class 3 and it's contraindicated. Okay, vitamin K antagonist, are they a good choice? No, sorry, they are not anymore a good choice. We have been suffering for decades from the vitamin K antagonist therapy. Why? Because of the variability in the dose response, unpredictable pharmacology, interaction with food and drugs, and even genetic polymorphism. They have, as you know, a narrow therapeutic window, and because of this, for decades, they definitely underused. Very narrow therapeutic range, below 2 risky, above 3 risky. Because of this, around 45%, almost half of eligible patients did not receive the proper dose of warfarin. This is an overall. However, the incidence is increasing as you go more and more older with your patient. So warfarin definitely had been underused in the treatment of non-valvular atrial fibrillation for the last 40 or 50 years. What about the novel oral anticoagulant or direct oral anticoagulant? Yes, for stroke prevention in atrial fibrillation, according to the guidelines everywhere, including guidelines last week, they are recommended in preference to vitamin K antagonist as class 1 level of evidence A recommendation. Definitely, they are of choice better than vitamin K antagonist. The only exclusion is patients with mechanical heart valve and those with mitral stenosis, moderate to severe mitral stenosis. By moderate to severe, we cardiologists mean mitral valve area less than 2 centimeters square. Only these patients, NOAC could not be given in the aspect of atrial fibrillation. According to the recent guidelines, the last week, European guidelines, we have to search for what is called modifiable bleeding risk factor, because if we manage to treat the risk factor of bleeding, we will get less and less bleeding to our patient, and in the same time, we will be able to give them the optimum protection against stroke. Again, NOAC definitely better than vitamin K antagonist. Fast onset, reducing potential food and drug interaction, no need for routine coagulation monitoring, and this is very important, simplified fixed dosing regimen, and most important, predictable anticoagulation response. This actually led to improved benefit risk profile, quality of life, and reduced administrative costs. Okay, is it important to assess renal function in patients with atrial fibrillation? Yes. Professor Valerio stated clearly that every third patient with atrial fibrillation has chronic kidney disease. Chronic kidney disease is very strange regarding bleeding and thrombosis. Patients with chronic kidney disease has more bleeding risk compared the red bar chronic kidney disease with the non-chronic kidney disease patients. And in the same time, they have more thromboembolization and the stroke risk. The red bar, again, patients with chronic kidney disease, compare this with those without kidney disease. So patients with chronic kidney disease, more bleeding risk, and in the same time, more thromboembolic risk. The guidelines was clear. The American guidelines stated that we should assess renal function in our patients with atrial fibrillation class 1 level of evidence. Okay, what would be your choice in patients with atrial fibrillation? You need to prevent his stroke and he has renal impairment. What to do? Is it dabigatran 110 twice daily will be our choice, or apixaban or rivaroxaban? Regarding dabigatran, just forget it. 80% excreted through the kidney. Professor Valeria elegantly showed us a table when the half-life of dabigatran exceeding 25 hours. So it should be discarded in patients with renal impairment. What about apixaban? Apixaban, actually, we don't have data regarding the 2.5 milligram dose. No studies on this dose, probably because in the Aristotle trial, only 4.7% receiving this dose. And subsequently, they did not have sub-analysis regarding the study of this reduced dose, especially in our particular renal impaired patient. Actually, rivaroxaban 15 milligram is the only novel oral anticoagulant that have a reduced dose well studied. As we will see that a good percentage of the rocket atrial fibrillation famous trial had 15 milligram dose and a good percentage with renal impairment. So for the first time and the only trial that we will see what this dose will do to these patients with renal impairment. So this is the atrial fibrillation, rocket atrial fibrillation trial. This is a sub-analysis. They chose patients with renal impairment, creatinine clearance between 30 and 49. Those patients were given a reduced dose of rivaroxaban, 15 milligram. As we can see in the rocket atrial fibrillation, they have the highest risk patients, Schatz score 3.5 mean, and around 21% had renal impairment, very high risk patients. This was compared to 15% only in the Aristotle and 19% in the Rely. And we have a specific dose for this patient in the atrial fibrillation rocket trial. And we will see what the reduced dose did to the renal impairment patient. Was it protective? Was it risky? This is, I'm going to show you, my dear colleagues, right now in front of you. To your left, we have patients with impaired kidney function, and to the right, patient with creatinine clearance over 50. You can appreciate that there is a consistency of efficacy of rivaroxaban versus warfarin in patients with chronic kidney disease, similar to those without chronic kidney disease. Okay, but this is not enough. I need to check the safety of rivaroxaban versus warfarin on patients with chronic kidney disease in the reduced dose. Yes, here it is. Again, we have a consistency of safety of rivaroxaban 15 milligram once daily regarding critical organ bleeding. Compare rivaroxaban in the red bar with the one of the brown bar of warfarin regarding critical organ bleeding, much less intracranial hemorrhage, much less fatal bleeding, much less Caesar hazard ratio. Of course, the rivaroxaban 15 milligram once daily in patients with atrial fibrillation and moderate renal impairment was protective and safe. So the patient with high risk profile, more thrombosis and more bleeding, now we have a molecule, 15 milligram once daily, that offers us more protection and safe in the same time. Rivaroxaban 15 milligram once daily. Okay, back to my patient He is afraid, as I told you, from cardiovascular mortality, from peripheral vascular disease, from dialysis. Okay, let us discuss how to protect my patient, please. Okay, he is diabetic. Okay. And being a diabetic, carry a special extra risk factor, reminding you that lucky enough, the Rocket atrial fibrillation trial, 40% of these patients has diabetes compared with 25% in Aristotle and 36% in Engage atrial fibrillation trial. So the highest risk of Rocket atrial fibrillation is now receiving rivaroxaban. What is the protection level? Subgroup analysis, diabetic patients, Rocket atrial fibrillation. Okay, rivaroxaban was able to reduce the stroke. We all know this factor, but the surprise that the rivaroxaban intake also reduced cardiovascular death in the high-risk diabetic patients in the Rocket atrial fibrillation with relative risk reduction 20%. Same protection as a stroke. So rivaroxaban protect my patient not only from stroke but also from cardiovascular death. What about peripheral vascular disease? Rivaroxaban protected the patients with peripheral vascular atrial fibrillation from the major adverse limb events much more compared with warfarin. So it's protective regarding peripheral vascular events as well. Okay, my patient had worries against dialysis, progressive renal disease. Would rivaroxaban be able to protect him against further renal deterioration? Okay, rivaroxaban again in patients with diabetes was able to prevent the progression to acute kidney injury and to stage 5 chronic kidney disease or need for hemodialysis compared with warfarin. So it is not only protective against stroke, it's protective against cardiovascular death, peripheral vascular disease, and worsening of kidney function, especially in patients with diabetes. Being given once daily, giving him the advantage of maintaining and compliance of the patient. In this, we can appreciate that inappropriate underdosing does not offer an efficacy or bleeding benefit or problem if rivaroxaban was used. Compare this with apixaban. Any inappropriate or underdosing of apixaban will cause a major problem, whether I'm talking about stroke or bleeding. Compare this with rivaroxaban. Missing a dose did not cause such a tremendous harm of stroke or bleeding compared with apixaban. So, ladies and gentlemen, my practical last points in patients with non-valvular atrial fibrillation, according to the guidelines, NOAC are preferred. Rivaroxaban 20 milligram once daily should be our preference in preventing stroke, to be taken with food. If you have your patient with moderate or severe renal impairment, I'm talking about creatinine clearance 50 down to 15, you may give rivaroxaban 15 milligram once daily. You will get a full protection and full safety in treatment with such high risk patients. If your patient is on vitamin K antagonist, just wait till INR is below 3 and start to give rivaroxaban in the recommended dose as we just mentioned. Of course, if my patient with rivaroxaban had to do surgery, please stop rivaroxaban 2 days before elective surgery. If it's an emergency surgery, go to the bleeding risk profile of your patient. No bleeding risk profile, just go to surgery. It's an urgent surgery. If he has a severe bleeding risk profile, you have to give prothrombin complex concentrate before surgery. You have to understand the concern of physicians. They are always has phobia of a risk of bleeding, but you also have to appreciate the concern of your patient. He always have a phobia of risk of stroke. So you have to give an agent that give you full stroke prevention and in the same time safe regarding the risk of bleeding. The last European guidelines last week suggested a module for patients with atrial fibrillation for different specialties, and here we are in different specialties. So I thought I should mention what they suggest. It's an ABC protocol. A for anticoagulation and avoid stroke. Top priority. Top priority. Any Shatz-Vasc score 1 or more is indicated for anticoagulation. We have a slight difference between men and women. Men are more vulnerable, but it's okay. You have to choose the optimum oral anticoagulant that will be given to your patient according to the wealth of data and knowledge we have nowadays. B, for better symptom control, optimize rate control or go to rhythm strategy control using ablation, antiarrhythmic medications, or even cardioversion. And C is important. Just control the comorbidity and the cardiovascular risk factor. When I talk about atrial fibrillation risk reduction and stroke prevention, I have to consider all these items, starting from heart failure, vascular disease, valve disease, inflammatory disease, obstructive sleep apnea, and so on and so on. Back to my patients. After I share some of my thoughts with you, dear colleagues, this evening, I decided to take the concern of my patients with non-valvular atrial fibrillation, impaired renal function, and diabetes. He is 76 years old. I decided to take the concern of my patients very seriously. I decided to do all my best to prevent his stroke, preserve renal function, reducing his limb events, and reducing bleeding risk, prevent cardiovascular mortality, protection him from any stent placement in the future, optimizing the dose, and continue supporting and keep him adherent to treatment. I decided to give him rivaroxaban 15 milligram once daily. Thank you.
Thank you very much, Professor Mohammed. Very illustrative presentation. And I think we have now time to answer the questions. But before the questions, I have some slide to share with you also, because as you mentioned yourself, and chronic kidney disease, and I think being a nephrologist, I'd like to share my slide if there is a possibility. Being a nephrologist, I think all are interested now in measuring GFR and serum creatinine in order to prescribe proper medications. So let me just share a few slides, just less than 5 minutes. It is to be mentioned that stroke is among the major adverse renal cardiac events, but it's underlooked. And as you mentioned, Professor Mohammed and Professor Valeria, that in patients with CKD, AF is very common. It's almost 20% in non-dialysis patients and up to 40% on those on dialysis. And CKD also is very prevalent in patients with AF and discovered accidentally. It affects directly the lifespan of CKD patient as well as the dialysis patient. It shortens their lifespan. It is to be mentioned that the guidelines are defective regarding anticoagulation in such patients. The most recent is the American College of Cardiology and the American Heart Association, American Stroke Association, that mentioned that we should consider the reduced dose of NOAC if the GFR is 15 to 50, like Professor Mohammed mentioned very clearly, and they consider warfarin or apixaban. It's to be said that the guideline before that has mentioned that they are not to be used in patients on dialysis, either rivaroxaban, dabigatran, or apixaban, and only allowed warfarin. And this change in the guideline occurred when the American Heart Association and the American College of Cardiology have decided that dose of 2.5 or 5 VID are allowed in those on dialysis. And if you go deep, why they did so? They studied just 8 patients on dialysis. So they took this advice from them. Although we know that in the ROCKET AF, in patients with GFR 15, there is more significant reduction in MACE, as Professor Mohammed mentioned. And also in this very recent study just published in May 2020, rivaroxaban, when measured versus warfarin, showed the same efficacy with slightly less bleeding risk. So they are as equivalent in reduction of this of stroke in patients with chronic kidney disease. And in the RELOADED study, which is a retrospective German insurance claim database study, have shown that rivaroxaban is better than apixaban in reduction of progression to end stage as well as incidence of AKI. And this was true in patients who are already have renal disease and in those with diabetes. And so protection is very important against AKI. Professor Valeria mentioned a different mechanism of protection. Among them is vitamin K activation by vitamin K suppression by the warfarins that may cause increased calcification in the kidney. This is another study, a US market scan claim, again, the same like the German study, have shown that AKI and progression to end stage was significantly reduced in those patients receiving rivaroxaban. Versus warfarin, it's better in protection against stroke, ischemic stroke, and there is significant less major bleeding, which is very important because bleeding is very common in patients with CKD and dialysis. So what about direct comparison between rivaroxaban and apixaban? This is a very recent study, January 2020, showing that there is actually no difference in patients on dialysis between the two medications. There is no difference whatsoever between using rivaroxaban and apixaban in patients on dialysis. And the number, 780 patients in rivaroxaban versus 1,800 patients in apixaban. So the conclusion, they are the same in protection. And when they compare, this is again very interesting study just published last month. When they compared apixaban versus no anticoagulation in patients on long-term dialysis, apixaban was protective at the dose of 5 milligram, but not at the dose is do nothing for dialysis patients, but bleeding risk is markedly increased with the 5 milligram. So the conclusion of this study, there is no significant difference between giving or not giving apixaban in patients on dialysis, but there is high risk of bleeding with the high dose. So this is what I want to present before going into the discussion, because we have a lot of questions, and I'll start by the first question. The first question is, should the dose of rivaroxaban be reduced for patients with non-vascular AF whom age is above 75 years old? I think this question goes to Professor Valeria because she mentioned the age in her presentation.
Absolutely. I don't know, the camera is not on, but I think you hear me. The age is not a contraindication of treating patient with rivaroxaban 120. As I said during my talk, that you need to, the higher is the age, the higher is the risk of having complication. So absolutely maintain the full dose, the right dose for the right patient.
Professor Valeria,
yes.
If I have a patient above 90 years of age, he's underweight, and normal renal function with non-valvular atrial fibrillation, would you still give him a full dose of NOAC, or would you consider being frail, giving him reduced dose? What do you think?
Not for, there is some indication for apixaban about the low dose, about reducing the dose when you are more than 80 and weight less than 60 kilograms. I honestly, we don't have this indication for rivaroxaban. So honestly, I would maintain, with a good renal function, I would maintain the full dose. Okay. But I'm afraid of stroke. So my full attention is in stroke prevention.
Actually, we cardiologists also are afraid from bleeding, actually.
Yeah.
Because those patients are very vulnerable. Even when we do intervention and give them dual antiplatelet, usually we are encountered with some local complication, GIT complications. So bleeding catastrophes are always in our mind. So it's a balance between stroke prevention and bleeding reduction. Yes.
When we talk now about stroke and hemorrhagic and ischemic stroke, we think that is let's say, different phases of the same medal. So we have to protect the vessels. I agree that I see this as well, especially we use DAPT in very short periods, not more than 3 weeks. So we have shorter periods in doing double antiplatelets. But for when I think about this microembolization, I'm very, let's say, it's everything. It's not an easy decision, but I'm very confident of protecting the brain.
What about management of stroke patient, recent stroke, while he is in atrial fibrillation, whether recent or old? Would you maintain his oral anticoagulant or you stop it for a while?
So this is a very good question, because we have different scenario. Patient with atrial fibrillation without no treatment, then you are based on the size of the lesion. You decide when to start anticoagulation. When you have a very small lesion, you start it after 48 hours. When you have a moderate, around 5 centimeter lesion, then you wait 6 days. When you have a large lesion, then you tend to wait for 12 days. But in the time that you don't use anticoagulation, you treat this patient with antiplatelets. But after the time of interruption of anticoagulation, then based on the lesion size, you restarted anticoagulation.
Who judge the lesion size? Usually a neurologist or a physician like a cardiologist, or what do you think?
Let's say a neurologist, it's clear there's a lot of experience combined, but you can also find, let's say, objective criteria about the size, about the 5 centimeters. So it depends on how much experience do you have. But I think in a good university hospital, I would always use the resource of interdisciplinary discussion, because it enrich our experience. I talk a lot with my cardiologist, so I think this interaction is always very, very positive.
He is lucky. Actually, I saw a lot of patients with recent stroke, and once the doctors in the ICU started anticoagulation, they deteriorated because of the lesion transformed into a hemorrhagic stroke. So I think neurologists should be there from the first hour.
Yes, especially cardioembolic stroke in the acute phase have a higher risk of hemorrhagic transformation. So it's very important that you balance the risk benefit.
Okay. Professor Magdi, we are waiting for questions. Okay, it seems that Professor Magdi have some connection problem. Okay, Professor Valeria, can I ask you about Alzheimer's disease among patients with atrial fibrillation, dementia in general, non-vascular dementia? Why it's more prevalent among atrial fibrillation patients?
This is a good question, because we know that atrial fibrillation increases the risk of cognition. And probably what we learned in our medical school, the strict, let's say, division between degenerative dementia and vascular dementia is not so strict. Often there is a mixed feature. So we have, even in a patient with Alzheimer, we have a vascular component. So it's not only degenerative beta amyloid, but also the vascular part. So by protecting microembolism, we protect our patient also from dementia.
Okay. I can see Professor Magdi is back on board.
Yes, I'm sorry for the internet. I'm in Alexandria. It has one of the worst internet in Egypt.
But it has a beautiful in Egypt.
Yeah. Okay, there is another question about if the patient is on anticoagulation and develops stroke, when to be back and when to use anticoagulation again?
It's about what we said about the lesion size. It depends. Small lesion, TIA, you can start almost immediately. a small lesion for 25, 48 hours, medium lesion 6 days, and large lesion 12 days. Clearly, when you have hemorrhagic transformation, you have to wait a little bit more to clear it.
I know that there is a guidelines, but I believe that we should consult neurologists before starting anticoagulation for fear of hemorrhagic transformation. It's a dangerous decision without a neurologist on your side.
So what about if it wasn't already hemorrhagic stroke? And he is on.
Sorry.
So
go
what
ahead.
can we, for how long should we stop the new oral anticoagulant?
So for this, there's a study of, there are only observational studies, and the best times seems to be to wait 1 month. But sometimes you have 1 month. Yes, this is the medium, let's say, mean length of waiting. But sometimes you have very small hemorrhage. You can do it a little bit earlier, especially when you have a high Chasva score, when it's a deep hemorrhage, because we have to distinguish also between deep hemorrhage, which is a subcortical, which tend to be due to the hypertensive crisis, or cortical, which are more due to amyloid vasculopathy. So these have the cortical hemorrhage have a higher risk of recurrence. So probably these patients have a higher risk of rebleeding, while this subcortical deep hemorrhage are more due to hypertension.
Professor Magdi, I may add to the answer of this intelligent question. If I believe that the anticoagulant medications are beyond the central hemorrhage, I have to go searching for other modalities of management, like ablation of atrial fibrillation. Still, we are not sure about if we'll need anticoagulation after ablation or not. We don't have data yet. And maybe we use left atrial appendage closure device. This is an alternative to protect patients from further embolization. And in the same time, I don't go back to the anticoagulation. It's a very important decision in managing these patients.
Yes, absolutely. This is an alternative. Sorry.
No, go ahead. Yes, okay. So, Professor Mohammed, if the patient who has AF needed an urgent surgery and he's on rivaroxaban, what is the proper time to do the surgery after stopping the medication, and the proper time to reinstate the medication again afterwards?
Okay, of course, it depends on the urgency of the surgery. If it's urgent or elective or an emergency. And there are a difference between this terminology, of course, as you all know. And it depends upon the type of the operation. Is it something related to the GIT, vascular operation, a major operation in the heart, or whatever? The rule is to stop rivaroxaban 24 to 48 hours before surgery. If it's an emergency and I have to do it immediately, like appendicitis, I have to check the bleeding profile of my patient. If it's low risk for bleeding and it's low risk surgery for bleeding, just go and do it. If it's a high risk surgery and my patient is a high risk for bleeding, I may give him a sort of prothrombin concentration serum in order to prevent the risk of bleeding during surgery. The second question of yours, when to resume rivaroxaban. My answer is as early as possible, but I have to consult the surgeon. Is your surgery is okay? I can start warfarin tomorrow, the day after surgery, he will say to me, it's okay. No, I have still bleeding. I have a drain that is bloody. Please wait for another day or two. So in consultation with a surgeon, I have to take my decision.
Okay, there is another interesting question about what to do if the patient has bleeding, either mild, moderate, or severe. I think we'll start by Professor Valeria and then Professor Mohammed will comment.
So when a patient has a bleeding, first of all, we saw the half-life of the drug. So the action of the drug is very short. So compared to warfarin, where we have a long half-life. So already stopping warfarin is something that, already stopping NOAC, you already reduce the risk. Second, for the 10A antagonist, you can use prothrombin in case of bleeding, and you have to control and you have to hydrate and so on. So these are, let's say, the current guidelines. Then hopefully we will have the full application of the antidote, which is still a study ongoing and so on. So compared to what we had with warfarin, we have shorter half-life, and we can stop the bleeding quite quickly.
For me, actually, I cannot remember that I suffered from any of my patients with a catastrophic bleeding from NOAC. And as just Professor Valeria mentioned, once you stop the medication, the risk will go down and the bleeding will cease. Of course, if you have a mild or moderate bleeding, it's not a problem. But if you have the rare cases of severe bleeding, you have to go for the antidote or use prothrombin concentration precipitated. And this is, believe me, Professor Magdi, a very rare condition. I'm not sure if any one of us recall a catastrophic bleeding from any one of the NOAC.
Okay. There is still two questions. The first one is, should we use new oral anticoagulant or rivaroxaban by name in patient on dialysis? If I'd like to answer, it is not yet approved, but it is used in many studies, as I have shown you. The same outcome like apixaban, which is again was approved just in the United States based on a very small study. So if anyone would like to comment on that, because I myself, if the patient is already using them, sometime they came when they start dialysis, they already on rivaroxaban before dialysis. And I have seen a lot of patients like that. They didn't stop the drug. They didn't mention that they are on the drug. And I haven't witnessed any side effect. But to say, yes, prescribe, yes, I cannot say that up till now. But I think it will be safe and it will be included in the next guideline.
Professor Magdi, you are the nephrologist. You are courageous.
Yeah, I know.
As a cardiologist, okay. I cannot describe rivaroxaban for dialysis patient. I don't have recommendation. If something went wrong, I am the one who will go to the prison. So still in dialysis patient, as a cardiologist, I may recommend warfarin till we get more data. I'm not sure. What do you think, Valeria?
Yeah, I agree, totally agree. Unfortunately, same for me. I cannot prescribe in the dialysis. I know from my friend of nephrology, they do. They have some. They know the kidney so much better than me. But I totally agree with you. I will not go to. I suppose happens something for other reasons. I will go to the prison.
So one last question, a very interesting question. Can we shift from warfarin? What to do to stop warfarin and start Levroxban? What is the time frame? How can we do it?
I
Professor
can
Valeria
answer.
first.
Okay, go ahead.
No, go ahead.
Just check the INR. Once it is below 3, you can shift to Rivaroxaban directly. It's very simple.
Yeah.
Okay, I think we don't have more questions, and I think this meeting was very fruitful. And of course, as mentioned, Professor Mohammed and Professor Valeria, a neurologist with cardiologist, and myself, nephrologist, will add a lot to education about new oral anticoagulant, about Rivaroxaban. How can we prescribe it? How can we protect our patient, not only from the stroke, but also for his heart and his kidneys. And I thank you very much for this wonderful meeting, and hope to see you again. And I also invite you to come to Egypt when the ban on travel occurs, and we will come to Italy, of course.
Sure,
we love Italy.
Sure.
Okay. Thank you very much, Professor Valeria.
On this condition,
thank you very much, Professor Mohammed.
Okay, on this condition, I may agree to end this wonderful meeting that will go to Italy next summer.
Okay, great.
To enjoy the weather.
Yeah.
Okay, and Professor Valeria will come to Egypt in the winter.
Okay, with pleasure.
In this case, I should thank you all. And actually, I enjoyed the meeting, the discussion, and the friendship. And we hope to see you again and again.
Okay, thank you. My pleasure as well. Thank you.
Have a lovely night. Good night.
Good night. Thank you.